So, uh, a- as of last time, we went through how uh, Pete Dawson wants to define anterior guidance. So, even though in the book itself he was not defining it for us, I think as we were reading it last time, we came to conclude that for what it's worth, on page 175, okay, on page 175, um, the key point he talks about right there, okay, I think gives us certain criteria that we are looking for. And I think whatever that people have been thinking about as a definition of anterior guidance, it has to be understood in light with the key points that he points out there. That it needs to be in harmony with the neutral zone, and it needs to be in harmony with the lips and with phonetics. Lips, what he means by that is lip support, okay? The inner relationship with the lips, okay, right? And then the harmony with centric relation and in harmony with the envelope of function. And we're going to continue to discuss that. I think what I wanted to say was in the procedure, I know that there, we talked about this last time, but wanted to just make sure. In procedure, in page 174 and 175, he goes through step by step, and I took the liberty of switching the order that I thought that based on how I understand this myself, as well as what I'm reading from Dawson's book, that step 6, refine incisal edge position using F and V sound. That should really be the first step. Okay. And then while you're doing that, you're looking at determine incisal edge length using the smile line. So you have to kind of look at that both together. Okay. One and two, back and forth, back and forth. Now, the reason why I'm starting with this aspect today is because when we talk about lower anterior, there's a little bit of a different message coming from Dawson again. So that before we dive into that, I wanted to make sure that we're all on the same page here. That's why. Okay. So you're looking at both the aesthetic aspect, both for the patient's self-imaging as well as you as the observer, okay? You want to look at how the upper anterior teeth appears to be. For most people who are youthful, okay, in our culture, I guess in, at least most of the culture that I'm aware of, just about everybody out there, we see that incisal edge length as it coincides with or frames or drapes the lower lip is what most people look at it as a pleasing anterior teeth positions, the smile edge, incisal edge. So you have to try to appease that, fulfill that criteria while you are fulfilling the F and V sound. Because the F and V sound at the end of the day can be quite flexible position. Okay. After you do that, depending on how tricky the patient, how demanding the patient is, and whether you have fixed prosthesis or removable prosthesis, then you jump to step 3, lip support. Okay. And that will be you're trying to satisfy that criteria while you are satisfying the criteria of 1 and 2, the step 6 and 5. So we're going from Dawson's book, step 5. Step 6 is the first one. Step 5 is the second one. Step 3 is the third one. Okay. After you have that determined, okay, reasonably where you want it to be, it does not mean you cannot come back to it again. You have to remember it's back and forth, back and forth. It's more of a you're making a how should I put it a, a statue. You are an artist, okay? And so you're going to go back and forth, back and forth. Okay. So then number 4 will be actually what Dawson calls step 9, evaluate S sound now. Okay. And we're going to be able to dive into that more today as we're talking about lower anterior. Okay. And then while you're doing that, as you're doing that, you establish lingual contour, step 8 becomes, as far as I'm concerned, step 5. Okay. All right. And then as you are controlling the lingual contour, automatically come with that is adjusting for the long centric, step 7. Okay. All right. Now, if you're thinking, if you're thinking, uh, what about step 1 and 2? Okay. And step 4. Now, step 4 is frankly, really, it should be included in step 8, which would have been my number 5. Okay. And that is as as he's talking about establishing lingual contour, which he says is anterior guidance. Okay. Well, I mean, that is part of the determining of the closure lip. He talks about lip closure, but essentially, as the mandible is closing, okay, you have to think about that whole thing over there anyway, um, as along with establishing of the lingual contour. Um, refine and verify lower incisal edge position. Um, yeah, to be honest, that should be part of again as you are establishing the S sound and the lingual contour, because when you are adjusting for the lingual contour of the upper, I don't see why you would want to limit only doing adjustment for the lingual contour of the upper at any point. What I mean by that is if you're looking at the lingual contour of the upper or vice versa, incisal edge position and the incline of the incisal edge, as in step 1, you need to do that at the same time. Sometimes you take it off a little bit from the top. Sometimes you take it off a little bit from the bottom. Okay. And then same thing as step 2, establishing central holding stops for the incisors. You need to actually do all of that steps at same time as you're doing it. Now, if you listen to me over the years, you'll understand that I am not really about establishing an anterior holding stop. If it happens, I'm fine with it. If it does not happen, I'm fine with it. Okay. So, so I don't think that's really a critical part. I would imagine that's a major departure for me from Dawson's philosophy, I guess. But as I've repeatedly told you over and over, if you follow through what Dawson's saying about the key points, that it has to be in harmony, and then eventually we're going to talk about long centric. By the time you satisfy all that criteria, it is actually rare that you're going to notice the front teeth actually contacting, and they're having a what they call centric holding stop. I never really set out to disclude the anterior teeth, to be honest with you, in my journey in understanding occlusion. But when I realized the importance of phonetic testing and the envelope of motion function and all that, okay, um, and when I started to satisfy that, I just naturally came to conclude that the front teeth oftentimes were not in contact. It wasn't that I didn't like that idea. I was taught that idea too. But as I saw the value of, respecting the neutral zone and the envelope of function and the movement dictated by phonetic testing, once you satisfy all that, then you come to the realization, oh, front teeth really don't touch. Okay. So that. Um, Whoever is logged in as iPhone number 8, I am going to ask you to, you don't have to turn on your camera if you're in a place where you can't, but at least send me a text who you are so that I have an idea about who are people who are logged in today. Okay. All right. So now let's go on to chapter 18, restoring lower anterior teeth. Okay. So lower anterior teeth, believe it or not, is critically important as well. And the reason for that is because it is indeed true. Okay. Okay. Thank you, Sachi. Okay. It is indeed true. Okay. That lower anterior becomes critical, especially as the patients get older. The reality is, as I said earlier, the smile line, how the upper front teeth drape, is a sign of youth. But if you insist on doing that on a patient who is, I don't know, I hate to say it, let's say 61-year-old male like me, and as I'm looking at myself as I'm talking to you, so this is perfect, perfect contrast. I'm looking at Sushmita and Mari smiling, and I see your upper front teeth. As I'm talking, I have to exaggerate myself to see my upper front teeth. Most of the times, as I'm talking, my lower front teeth are more visible. Now, my situation is slightly different in the sense that I'm actually skeletal class 3. So my lower incisor will be a little bit more exaggerated, right? But that this is the whole thing about age appropriate aesthetics. So if you have a 85-year-old guy coming in and he shows you a picture of GQ magazine and says, I want to look like this dude who's 25, okay? That's just not gonna work. Not just because we are doing age discrimination, but most likely the lower front teeth will not allow you to do that. Like yesterday, I delivered 6 unit veneers, lower anterior, okay, veneers for one of my patients, and and those teeth were just badly broken down, right? Badly broken down. But um, he's been a patient of mine for a long time. So that was the very last thing I did in his mouth, essentially. I based over time, whenever he was able to afford, I basically reestablished his posterior function of posterior support first, because he didn't have enough of that. Once I established that posterior support was stable, and he was satisfied with how he was functioning. Over the years, these treatment plans took a long time. Then, when he was able to afford it, I did the upper front because that was to him. He's in travel industry, and so he's a few years younger than me, but he, quote unquote, he wanted to project youthful looking. things. And I have to also admit, in his case, the upper front teeth were showing enough, and yet they were badly broken down. So I did the upper anteriors first. He was happy with that. Okay, and then once everybody was happy, stabilized, and he was wearing a night guard, and I felt over the years he was satisfied. Then when he was ready with his money, we went ahead and we did the lower front. Now, as I did all that step by step, I made sure at every interval that the front teeth were not touching too much, right? And yesterday, indeed, the same thing. Okay, um, and 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 it's really critically important that we learn how to communicate with the lab, right? Even under the best circumstance, what you ask the lab is not what you're gonna get. Okay, not because they want to screw you, no, but because that's just the nature of the whole thing. Even if we do digital design and everything, you know. So, so I wanted to just kind of, share with you. I'm sorry, I don't, as I'm getting older, as I'm getting lazy, I don't like to take pictures of my clinical cases. Okay, so I don't have pictures to show about this case, but yes, Marty, Mylene, yes,
Hi.
hi.
Yeah, I just before we move on, I wanted me to ask a question about the incisal edge position.
Mm-hmm.
So back in chapter 15, it says like the envelope of function dictates the incisal edge position,
Mm-hmm.
but I thought it was the wet dry line
Well,
that
so
determines the
so
incisal
you
edge
start you
function.
start out with the wet dry junction line. You start out from there. Do you remember I said from a phonetic and from our observation, that is where we want to have our maxillary anterior incisors. Okay? However, remember I said that because the hard, that's a soft rule, literally because the lip's soft, but that's a soft rule in the sense that from there, if somebody wants to have a rabbity teeth, you can pull them out a little bit. If somebody wants to push it in, you can push it in a little bit. The hard, the really not non-negotiable is how it relates between upper and lower. But when you first set up the upper anterior teeth, okay, if you have no teeth in the mouth, whether it's full denture or implants, then we start out with the upper front, okay? And then when you are doing that, I said the starting point is the wet dry juncture. From there, you can go up and down depending on the patient's individual taste, front and back. Once you have that established in a reasonable position, then you put your lower incisor to match to that based on the phonetics and the range of motion and everything. Now, theoretically, if you think about it, if somebody truly wanted to start out with the lower front and then have the upper front match to the lower front, you could do that too. Like, for example, I have a patient right now that I saw earlier this week. I mean, this poor, she's in her, she told me she was 80. I couldn't believe that. I mean, she looks so young for that age. But essentially, she had upper implants, basically upper arches implants. Okay, but somebody gave, and it's been a long time she had it. Okay, um, so but somebody made it so that her upper incisors are like this, literally. It's not like this, but it's literally like this. And then her lower front teeth are banging it like this. And so that's why it's becoming loose. And so that's why she came to see me. She's like wondering, what do I do? What do I do? You know. And so looking at her and her skeletal profile, to be honest, and her lower front teeth were proclined. It would have been easier if the lower front teeth were retroclined, so we could do this. Okay? So where the lower front teeth is at can determine how we want to do the upper. So if you truly wanted to, and I'm not trying to confuse you here, Mylene. Thank you for remembering. And yes, my preference and Oral Pound, who populated the idea that we should use phonetics for doing all these things. Okay, it's not my idea; it's Oral Pound's idea. Okay, that we should start out with the upper front. To me, it makes sense. And the reason why they started doing it that way is because it came from their effort to learn to make dentures. Okay, dentures. Okay, and then, but it just happened to make sense. Okay, now Dawson's idea that he talks about in next chapter, he goes, well, the babies get lower incisors erupted first. So we should let the lower front teeth get to that point. And that's why in the previous chapter, chapter 17, he talks about defining the lower incisor, this and that. Frankly, I'm not vested either way, either way. And so what I do is if my patient has the lower front teeth in place and they are missing the upper front teeth, yeah, then I'll match the upper teeth to match to the lowers. Okay. So So I think what's important, Mylene, here is not to have a rigid rule, okay, but to understand the interaction between upper and lower is the critical part. Okay.
Thank
Okay. Thank you. Okay. Yeah. Now, so let's get back to page 178. Okay. And I'm gonna see if I can put this here so I can read my book. Okay. So he starts out by saying, page 178 on the upper left hand column, the very first sentence, he says, do not downplay the importance of the lower and anterior teeth. The arrangement of the entire occlusal scheme starts with the lower anterior teeth. Just as the erupting lower incisors are guided into position by the tongue and lips before the upper anterior teeth erupt, so too must lower incisal edge position be determined before the position and contour of the upper anterior teeth can be finalized. So he's implying before you can quote unquote finalize that you need to look at these things back and forth, back and forth. And when he talked about the erupting teeth, that is true. The lower, if you look at the babies, lower incisors always come out first, almost always. Okay, you know, um, so I'm okay with that. Okay, um, um, but just just remember, we have to be willing to move them back and forth. And what just came to my mind is, in my defense, is that indeed, even if the lower incisor comes up first, lower incisor is very movable because our jaw is very movable. Okay. Now, somewhere along the way, Dawson talks about how the orthodontists also look at lower incisor position as sort of the guidance for them to do what they want to do. Mm, I don't know about that because I also know another school of thought in orthodontics where they primarily determine maxillary anterior teeth first. And this group of people are the people who really emphasize intervening at mixed dentition level, okay, to set the arch development and everything. And those guys, distinctly, I remember, they talk about how they want to have a relationship of the maxillary anterior incisors as it relates to the palatal bone and as it relates to the lower lip and as it relates to the overall facial profile. And their idea is that mandible will follow that, okay, because the mandible has the ability to move, okay. Now, orthodontics and what we do prosthetically, we need to keep each other in mind of each other. But I would say, we got different tools, so we're not going to necessarily mirror each other all the time. Okay. Okay. Um, so yeah, he says that second paragraph, I'll just read the first two sentences. Determining the correct position of lower anterior teeth is one of the most important decisions we must make in planning restorative treatment. The position of the lower incisor is also recognized as the first priority in orthodontic diagnosis and treatment planning. I'm not sure, but okay, let's move on. So, five important goals in occlusal treatment depends on correct position. I jumped over to the next paragraph and contour of the lower incisal edge. So he's talking about aesthetics because during speaking, most visible part of the dentition is the incisal half of the lower anterior teeth. That's if you're a more elderly person, right? Number two, phonetics. The spatial relationship between the lower incisal edge and the opposing tooth surfaces are critical to the formation of various sound patterns. Okay, now occlusal plane number three, lower incisal plane is the starting point in front for the occlusal plane. Okay, I don't have any problem with that. Okay, anterior guidance, and then the stability. Okay, so on the stability, let's just read real quick. Long-term stability depends on harmony between the teeth and the structures that relate to them in function. If the teeth interfere with anatomic or functional harmony of those structures, the adaptive process will attempt to correct imbalance. The result will be the loosening of teeth, excessive wear, or tooth migration. And I wanted to emphasize exactly what Dawson said there. Exactly. That if the if these things are not in harmony, okay, in my opinion, I think a lot of times occlusion keeps on changing, both the mandibular position as well as teeth positions, because that is actually part of adaptive process of human mascatory system. And that is part of my logic in saying that almost every adult who's past midlife should be wearing a occlusal splint night guard, as I describe it. And the reason is because every night you want to minimize the need for your occlusion and mandible to adapt to the abuses you have put yourself through by clenching, grinding, eating certain type of food, things like that. That if you wear or if you provide a splint night guard that mimics optimal occlusal relationship, that there will be less need for adaptive changes our mandible and teeth make. Like if I say this to most dentists when I first met them, they'll be thinking like, what is Tom smoking? Right? But I hope to you, after having read this book so far and how we are understanding the intricacies, the physiology of the muscles and the bone and the teeth and so forth and the PDL ligaments and all that, I hope you begin to appreciate that. Okay. And that is just so true. And this is the reason why most research about the relationship of orofacial pain and occlusion fail to yield that connection because the researchers don't understand this adaptive relationship. To them, to them, either a system works good or bad. There is nothing in between. Okay? You know, the reason why people become at least type 2 diabetes, okay, become that is because they keep on loading their body with more sugar than your body wants. And to a certain extent, type 2 diabetes is actually an adaptive process from our liver and our kidney to all the extra calorie that we're throwing it into ourselves. So the reason why I'm saying that is that our body goes through that adaptive process every day in every part of our body. It's not just a dentition. Why do we go to the gym and work out? Right? Because we want to take advantage of our adaptive process where our bone gets stronger, our muscles get stronger, we get better stamina, right? So that's an adaptive process. Our occlusion, so when I say our occlusion changes, it's dynamic and this and that, okay? A lot of that is adaptive process. And that's why I tell my patients, don't eat hard food too much. Why is that? Because if you look at patients eating hard food and you observe for yourself first, if you go ahead and sit down and enjoy your favorite nuts, okay, favorite food that happens to require meaningful chewing, you're going to notice most of us chew only, especially those hard food, only on one side, right or left. Within the entire meal session, very rarely will people chew right versus left evenly. Okay. So if you only chew, which for me, almost on my entire adult life, I used to chew on my left side. I'm trying to shift over to the right side now, believe it or not. Okay. But because of that, my musculature, okay, develops. And if my musculature develops into that, then my skeleton will follow. Remember what Dawson said, between muscle and teeth, muscles never lose. Between muscles and bone, muscles never lose. If you look at people who have slightly or sometimes noticeably skewed asymmetric face, like if I look at myself, I am slightly longer on my left side than on my right side. Okay, and the reason I hypothesize is that is that however the dynamics work out, my load that I give onto my jaw is such that my musculature and my condyle on my left side continues to grow and or my condyle and my muscles on my right side atrophies relative to the left side. You you're gonna notice that as you get see people. And if you catch those people, especially when they're young enough, and if you can change their occlusal schematics, okay, starting with the night guard splint therapy, you're gonna start to at least stop that asymmetric growth potential, the direction. If not, start to correcting it. The reason why I was only chewing on my left side for my all my adult life is because during my dental school, one of my upperclassmen was working on me and he screwed up. So I was missing half a tooth of number 31 from my dental school third year, second year, all the way to, I'm going to say about 5 years ago. Okay. And so because and then I finally so I was missing a mesial root of number 31 for all that year, all those years. And then about 5 years ago, the distal root of number 31 finally gave up, so I pulled it out. And I kept my number 32 as a vertical stop just in case. This was a decision I made way back when I was extracting number 116, 17. But 32, because it didn't have 31 in the front, even though I didn't really chew on my right side, eventually got loose, a short root. So I took that out, and I've decided to put an implant in on my right side. But I could tell as soon as I didn't have my number 32 or even 31, missing space there. Okay. Right now, I just have an implant in number 31 position healing. Okay. I could start chewing more on my right side comfortably. So all these years, my number 32 was giving me interference, which I kind of knew, right? Okay. So now I'm able to go back and forth at will. But prior to that, it was really awkward for me to chew on my right side. Anyway, so when you take a look at this chapter, there is a lot about trying to determine lower incisor position per se. Okay. But he spends a good amount of time, and I think this is actually very good, talking about how he communicates to the lab, right? So on the page 178, okay, I'm gonna go down on the right-hand column all the way at the bottom, very last page, okay, 178, very last page, part of the page on the right side, the last sentence, okay. As I learned how important minute details were to the finished result, it became obvious that we needed more precise, verifiable methods of communicating every detail. It also meant that before I could communicate any precise detail, I had to determine exactly what I wanted. Okay? So, if I was to do, if you look at essentially what I did was yesterday was what the author did in this later in this chapter. So let's take a look at what would be a good picture here. I'm not really sure. He doesn't explicitly say it. So, but let's go to page 185. Uh, he has the figure 18-10, lower right, all the way at the bottom. Provisional restorations in the mouth. So I'm assuming that's a provisional restoration for the both entire upper and lower. Okay. So what he's saying is that no, so he went through step by step here, and he did the diagnostic wax up a little bit. You can see on the left hand column of that page 185, and then he sort of determined figure 18-8. Diagnostic wax up helps determine lower incisal edge position for the holding stop, at which he's insisting. Okay. And then look at him, 18-9. He's adjusting upper anterior teeth to accommodate lower incisal edge position. So now he's doing adjustment of the upper lingual, right? But what if there is no room for doing that? Because if you look at actually on that cast, take a look at, so he's carving on lingual of number 8 on figure 18-9. what about the tooth number 9? Take a look, number 9. That's like chipped off at the edges. The lingual is half broken off. Let's just say if that was touching, are you going to continue to do lingual contour adjustment? A little bit, but not too much. I'm afraid I'm going to be left with nothing. Now, if you come to the conclusion, you have to restore number 9 in that picture, 18-9. Okay? I'll tell you, my go-to method for that, uh, besides just direct composite, if I had to do a fixed restoration, would be veneer, not crown. Because if I had to do a crown on that, it's already chipped away like that. I'm gonna have to reduce so much, there's gonna be nothing left on that tooth. But if you can imagine, if I under remove the anterior and make my veneer come out a little bit more facial, if I can convince the patient to do that, okay? And I just do a little bit more enamelplasty on the lingual, okay? I'm gonna end up with far more tooth structure on that tooth, okay, than if I were to do a crown. So in the upper front and lower front, it is quite often that when I am doing rehab for broken down teeth, that many times I will actually opt to do veneer because I end up with more tooth structure. So I will mix and match veneer and crown, mix and match depending on what is my remaining amount of tooth structure, what do I anticipate after I'm done with my prep, and what is the relationship that I need to satisfy with the opposing. Okay? So, so so when you look at that cast on the left-hand column of that page, so I think that's the same cast I can see, right? Number 8 has it looks like it's a crown, and number 9 has the incisal chip there, right? You can see that. Okay. Now, when you look at the bottom, when you look at the bottom of that anterior look, frontal look of the cast, upper and lower, where does that patient need more of the buildup? In the lower front, number 23, 24, 25, 26, right? Okay. Obviously, it's difficult. I don't know if he shows the picture of that case completely before they start adding anything, but what I'm going to try to say is this. What I'm going to try to say is this. Whether it's tooth structure or a crown, whether it's a PFM, gold, zirconia, Emax, it doesn't really matter from my experience, okay? Or tooth structure. If they're banging hard, it's going to cause wear on the opposing. You can't tell me that number 9 caused less damage to the opposing compared to number 8. They're equally guilty. That's all I'm trying to say. I'm not suggesting zirconia is okay, this or that or whatever. I'm not suggesting that. Okay? I'm from the era that we were worried about PFM being too rough, too coarse for the opposing. Because they talk about how zirconia is so abrasive against the opposing. And that a lot of the dentists will use that as an excuse to justify how they're going to give a light occlusion for the zirconia crown. Okay? But forget the fact that it's going to screw up their occlusion really badly. Okay? But anyway, so Going back to where I left off here is this. Dawson's desire of determining exactly what he wants. My desire to know exactly what I wanted when I did lower anterior six veneers. How do I translate that and communicate that to the lab? So take a look at Dawson's prescription sheet for his lab on page 180. So apparently he has several different, yeah, on the on figure 18-1 he sees he has the picture of lower anterior, lower posterior, upper anterior, upper posterior. Okay, I don't know how different they are from each other, but let's just take a look at lower anterior because essentially they're going to be the same type of information. Obviously, a little different, but and all those details are, I think, critically important. But let's be honest, we don't have the luxury of an in-house lab for all of us. Okay. But what I thought that was interesting here was the top one. It says lower anterior, incisal plane. The top thing that you can actually check off is copy cast of temps. Remember what I told you always. Learn how to make a decent temp so that you can take a master impression of that cast temporary and send it to the lab so that the lab knows exactly what you have in mind, especially when you're doing the front teeth. Because otherwise, like right now, let's go back to the page 179. Dawson points out that there are primarily three different aspects about the lower front teeth that we have to be aware of. Number one, curvature of the incisal plane. Number two, height of the incisal plane. Number three, horizontal position of the incisal edges. Exactly. So how do you really write that out? You can't really write that out. You can't even take picture of it that easily. You know why? Because pictures of that can be very misleading depending on the angle and so forth. So if you are gonna try hope that the patient will that the patient will I'm sorry that the lab will need to follow through exactly what you want them to do, you've got to make a master cast, new cast of the temporary, and you have to be able to basically fabricate a temporary that you are comfortable showing the cast to the lab. Okay. So, I thought that was very interesting because now, as a dentist, to be honest, am I gonna worry about, let's say, 1, 2, 3, 4, box number 4, labial embrasures. Number 5, lingual silhouette. Am I gonna be able to like really spend time giving the lab that kind of visual with my temporary? No, not really, to be honest. No. Okay. Okay. What I am looking for is incisal position, just like page 179. Curvature, cant, curvature. Okay. Not only curvature as we're looking at it from the front, but curvature of the arc. Arc. Okay. Height of the incisal plane and horizontal position of the incisal edge. So like recently I had a patient, a a GP had spent a couple of different effort to try to restore the lower front implants for a patient. And the patient is in her like 80s and she's got implants everywhere. Upper anterior implants too. Okay. and they had recently extracted lower front teeth that were all breaking down, and then they put the implants in. And the restorative dentist was somebody that I'm familiar with, and he was like saying, Tom, can you take a look at this case for me? Because I followed everything you said, but the patient says patient's not comfortable, doesn't like it. So I looked, and yes, the front teeth were not touching too much, okay, and it looked good, in terms of visual and everything. Now, one thing that I immediately noticed was that the patient's phonetic testing was not done properly. So the patient wants to come forward, but the patient can't. So, the dentist asked me to just finish the restoration for the patient. So I went ahead and I went back to the provisional stage. And what I did was I created room for the tongue because I felt like phonetic testing was really tricky because I couldn't really quite tell. But I mean, the fact that she said she just was not comfortable. And when I'm looking at the arc, because I can see the patient is a almost edge to edge class 3 profile. Remember, as the patients get older, almost everybody gets to be edge to edge. Okay. And yet the the occlusal scheme, because the lab made it out of the digital design of the zirconias, they made it as a class 1. So what I did was I wanted to create more space for the tongue. But in order to do that, what I had to do was I had to bring the lower front teeth more forward. But I didn't want to touch the upper teeth, right? So what did I end up doing? I ended up making the lower teeth shorter, a little bit, not much, but shorter, and then I was able to procline it. Proclining of the teeth in the lower front with the implants allows more tongue space. Okay. But as I did that, I had to reestablish the S sound. So essentially what the patient ended up at the end was she became a classic class 1 with 2 millimeter overjet overbite. That's the way that the lab had zeroed in with the previous restoration. But I ended up with almost edge to edge, about 0.5 millimeter of overbite, no more than that, about 0.5 millimeter overjet. So the lower front teeth were straight up and down like this, but then they ended up like this. Okay. Still not touching in the front, eccentric stop. And then voila, magic. Patient says, Dr. Lee, I could eat now. I could talk comfortably for the most part. You know? So so then and then we confirmed that. I took an impression of that temporary, sent it to the lab. And guess what? Of course the lab doesn't follow, right? They're probably thinking like, why is this doctor wasting his time? So the only way that I can hold the lab responsible for is what? How do I do it? I demand I need to see your design. And then they show me the design and I go, but it doesn't look like you used my temporary as an overlay for your design. Can I take a look at how my temporary cast looks when you blend it in together here? And then they could see some difference. Yep, that's exactly why I sent you that temporary. Please make it so that it looks like my temporary overall profile, overall positioning, overall inclination. So it took like, at the end, actually, it took like 3 Zoom sessions, yeah, for me to get what I wanted. But at the end, yeah, patient finally accepted it. She's like, I can live with this. Okay. So, so this idea about range of motion as evidenced by phonetic testing, this idea about neutral zone for the comfort of your tongue, while still respecting anterior dentition relationship is critical. And the best way to communicate that sometimes is through sending them your temporary cast. Now, in the digital era, you can scan once you have your temporary, and then they can flip the arch to see how your provisional looks like. Okay? So, when you're looking at the curvature of the incisal plane, now I'm at page 181. Isn't it amazing how, so he's now talking about lower anterior, and he's now talking about phonetics in earnest. Okay? And yeah, I wish he would expound upon this more. This is what's confusing, you know. But in again, so the 181 upper left hand column, curvature of the incisal plane. The curvature of the incisal plane is as important to phonetic as it is to aesthetics. This relationship to phonetics has a profound effect on function, and mistakes in the contour of the incisal plane are often responsible for problems of discomfort as a result of phonetic disharmony. Okay. So what he is trying to demonstrate to you with figure 18-3, 18-4, 18-6, 5 and 6, all of them, is he's trying to show you how different people have different movements that go along with the different alignment of the teeth, okay? And depends on what is the opposing that you have to deal with. Very rarely do we have how should I put it, blank canvas that we can do everything, okay? But the most important part is whichever one you are keeping, upper or lower arch, whichever one that you have the ability to change, you want to make sure that you are able to, shall we say, um, 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 create the necessary phonetic relationship. Without the phonetics being satisfied, it will not be stable. Okay? Now, I do have one thing that I wanted to mention to you, which I pretty much disagree with Dawson more overtly in this setting, and that is figure 18-7. 18-7, he says, that's the ideal occlusal curve along lower incisal edge. You can see that the lower incisal edges are higher than the posteriors. I'm here to tell you that is not ideal. That is evidence, and he even talks about it himself, but with a different context. He talks about the fact that the teeth super erupt and the alveolar bone comes along with it. So when the lower anterior teeth appear to be like that, you can assume and validate, okay, that the front teeth have been touching too much. Okay. Lower incisal edge should not be at a higher plane of occlusion as compared to the posterior dentition in the lower. Okay? That means they're touching too much. Just keep that in mind. You're going to see a lot of these people in class 2, even when they're young, class 2. And then class 1 and 3, as they get older, you're going to see these things. Hmm. Now, page 182 on the right-hand column, he talks about height of the incisal plane, just so that we get to the meat of what I was just saying. Second paragraph on that. On the right-hand column, 182, from the top under the subsection of higher than incisal plane, second paragraph. Okay, if the incisal plane is greatly higher than the posterior occlusal plane, that is an indication of elongation of the anterior segment. Ha ha ha. That's exactly what I've been saying. Almost always the result of no stable holding context on the anterior teeth. Now, that part I disagree, but okay. But he recognized that it's elongation, okay, of that segment. When the lower incisors erupt, they do not erupt out of the alveolar bone. Rather, the alveolar process itself elongates, moving the teeth vertically until a stable stop is met. This stop preferably is the opposing tooth, but it also may be the tongue of the lip. The absence of any stop allows the lower anteriors to erupt all the way to the palatal tissue, creating an incisal plane that is at a different level from the posterior plane of occlusion. Now, that is the generic line that everybody uses. I'm just gonna say that if even if they're touching wrong, you're gonna continue to erupt those things, interference. Okay. Now, let's read the next paragraph. Okay. The critical element in determining the height of the lower incisal edges will, in most instances, be the relationship with the upper anterior teeth. Yeah. So, it's kind of like which came first, egg or the chicken. I am trying to set up lower anterior teeth, but he's like saying, in most situations, what really matters is its relationship with the upper anterior teeth. Yeah. So as I was saying earlier, it really doesn't matter which one you do first, as long as you're mindful of the fact that they have to have peace between the two. Okay. And then blah, blah, blah. Okay. So actually, I'm going to read. It is often necessary, the second sentence on the last paragraph. It is often necessary to reshape or reposition the upper anterior teeth to get an acceptable position and contour of lower incisors. This working out of both the upper and lower anterior teeth relationship is the first step in solving most of the complex problems of occlusal mal relationships. The goal is to establish stable holding context for the lower incisors at an aesthetically acceptable height. Okay? So I think, I think you now see that I may appear to be advocating something different than what Dawson is talking about, but truthfully, when you look at it, it's really the same, what I've been saying. Okay? Now, Um, the next one, 183, this is something to keep in mind. On the left-hand column, I'm going to say every patient does not look like the ideal norm in the textbook. So trying to adapt every patient's dentition to be average can result in some very unacceptable results. That's right. You don't want to go average value. You know who talks about average value all the time when setting teeth? Teeth to be where they are? all on four, all on six people. You go to their lectures and they're gonna say, oh yeah, anatomic average, your incisor should be at this position relative to your incisive papilla. Whatever. Okay. There is merit, however, in knowing what the norms are because they serve as basic guidelines toward which treatment can be directed. Yes. So don't talk about the average so much, but you know, be mindful of the individual patient situation. Now, so when you look at when you look at the wax ups and everything, the pictures on the sorry, the on the next page, okay. Let's take a look at um, 185, left-hand column, last paragraph. The question of horizontal position of lower anterior teeth is one of the most important decisions that must be made on every anterior restorative patient. It is a decision that cannot be made without knowing the jaw-to-jaw relationship in centric relation, which is the reason for using mounted diagnostic casts. I don't have any problem with casts, but if you are mindful of all those things, I'm not really sure if diagnostic cast is a must. Now let's just keep on reading. The diagnostic wax up is the best possible way to determine lower incisal edge position. No, that's a starting point, but no. Okay. On many occasions, it is necessary to alter the upper anterior teeth to accommodate an acceptable lower incisal edge position. By all means, you can adjust the lower or you can adjust the upper to match the other side. Remember that the diagnostic wax up is used with a putty matrix to fabricate the provisional restorations, which then must be refined to a final contour of the mouth. And you can see how they do the cutback of the wax up. I guess that's not, yeah, yeah, right. Cutback of the putty, and then now they're gonna use that same putty as a guidance or guideline for fabricating the final restoration, the previous generation of all ceramics. You can see how they more or less kind of catch that. These days, it's so much easier when you are just doing, AI design, and you just ask the computer to just, just ignore ignore all the other things and just focus on what you have given the lab, right? So, um, you know, this is the unfortunate part. You're seeing many pictures where there is missing posterior teeth, and the author is only relying on the incisor, lower incisors. I just want to tell you that if you indeed do the restoration of the lower incisors before you establish the posterior, the lower incisors would obviously become very much vulnerable. Okay. Now, if you have any questions about how the veneers are prepped on page 18-16, I don't have any problem with that veneer prep. I think I might have mentioned to you that in my opinion, I would have just broken the interproximal contacts. Okay. So you will be straight through and through, primarily because I want to be able to make sure I seat my restoration without slipping around, because there is going to be more mechanical lock if you break the interproximal embrasure space contacts on the enamel. Okay. Um, but otherwise, I thought that the case was done nicely, and I don't have any particular problem. I do think that knowing what I know, the lower incisors should have been and could have been slightly more retroclined for future problem avoidance. Okay. So now, um, any questions so far? No? Okay. Let's before we go to next chapter, long centric, because this one requires a little bit of thinking process also, much more so. Why don't we take a little break time here? I think this is a nice break time point. I see you like that, Nadi, huh? Okay. All right. So it's 10:18 now. Why don't we regroup at 10:40? Okay, so we're giving ourselves about 20-minute potty break. Okay, everybody? All right. Thank you.
Please don't forget to pause the recording, sir.
Yes, thank you. Okay. So long centric is a concept that different people have over the years have struggled with, try to understand. Da, 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 da. And at the end of the day, so I think it's important that we read. Let's just read this part here. So the page 190. I'm just gonna actually read from the top because I think we want to have some context. Centric relation refers to the exact point at which the loaded condyle disc assemblies are braced by bone at the most superior position possible against the eminentia. At this loaded position, that occurs from firm contraction of the elevator muscles, the disc is compressed and the condylar axis reaches what we refer to as the apex of force position. It is this position that can be located repeatedly and recorded with needle point accuracy. Consequently, it is somewhat confusing to think of such a precise point as being long. So he's saying that centric relation is a needle point dot. Let's just keep on reading this. He's like saying if it's supposed to be needle point dot, how can you have a long centric, right? The term long centric is misleading because there cannot be such a thing as a long precise point. It is even harder to accept the concept of a long centric with the current understanding that the medial pole of the condylar disc assembly is stopped by bone, which is unyielding, at least within the range of normal function. The original concept of long centric probably garners some advocates for the wrong reason, because they because of clearly erroneous belief that the condyle either rested in a yielding mass of soft tissue or was simply suspended in space. And I'm here to tell you that it is indeed, I said this over and over and over, centric relation is not a dot. Okay, it's not a dot. As he himself says it here. Remember previously I emphasized how Dawson is saying centric relation is bone to bone relationship. And I kept saying, no, it's not. There is a disk there at minimum. And if there is a disk there, how can you say that it's only going to be in singular position within the disk, the compression part, the elasticity part? No, it is just full of irony what they're claiming. Okay, these people come from a different generation. As I always say to people, who was I saying this to? I was saying this to somebody the other day that that I hope you take it to your heart. Just when in doubt, as I'm studying this occlusion with you, I use the word quantum occlusion, quantum mechanics. These are people. from Newtonian age. Everything they say has to be exactly spelled out exactly at that point. But as you understand the nature a little bit more, there is a lot of nuance to that. You know, in quantum mechanics, electron is not within that loop that you see in a nice atomic picture. It's somewhere there, but it's not in any particular spot. The fact that you try to look at electron changes its position. The fact that we hold the patient's jaw is going to change its position posture. The key is not to force the patient into a box, small box, just like anterior guidance. Okay? The key is to understand that they need to be within the within the position that satisfies so many different things. And by the time you satisfy all of that, you realize it is not a singular a pinpoint needle point dot. Okay? So it is really unfortunate that they keep on perpetuating this misunderstanding. Okay? All right. And and the reality is that whether you want to call it long centric or wide centric, because long centric implies it's just forward and back, but it could also be right left also. If you remember my lectures, that's what I try to emphasize. That you have to be aware of right left movement is actually more profound than the forward and back in a true centric relation concept. Yes, Mylene.
Hi, yes. Um, so am I hearing the idea is that it's repeatable within a range?
Repeatable within a range. Yes. Yes. Okay. And our criteria is to satisfy whatever the occlusal scheme that we're going to talk about once we start to get the posterior occlusion. Okay. That there is no interference within that range. That is the critical part. Within that range, if there is no interference, then there is minimal need for adaptation. And it is that adaptation that keeps on making your occlusion wander around. Okay, so thank you for that clarification. Okay, now so once you get that, then was there another hand, Mylene? No?
No, no.
Okay, so um, so you know I so just so that we are going through the book, page 190 on the lower right, he says 2 points about long centric should be clarified to facilitate further understanding. Number one, long centric involves primarily the anterior teeth. That's where we see it the most, but it is indeed the entire mandible. Okay. And I think he even says that in a healthy articulation of the condyles, there can be no horizontal protrusive path of posterior teeth, even with a 0-degree anterior guidance. The condyle must move downward as the jaw moves forward. The lower posterior teeth must move downward with them. Thus, a flat protrusive area is usually not necessary on posterior teeth, especially in the molar region. Well, I'm here to tell you, nope, because it's really the disc we're talking about, not the bone. It's the pliability of the disc, okay? That yes, you can have wide area that needs to be accommodated, even in the posterior, even in the posterior. Number two, long centric refers to freedom from centric, not freedom in centric. Well, I'm going to have to say, depending on how you mean by that, I'm going to say freedom in centric, as Mylene talked about, it's a wide range. So in that sense, I'm going to say it is in centric, not from centric. Okay? So I guess this chapter is the one that we have to profoundly disagree with the arguments that Dawson is making. So let's take a look at the drawings and everything, and starting 192. Okay. So, he starts out, on the upper left, contact in centric relation. Before long centric can be recorded, all posterior interferences to long centric relation must be completely eliminated. Okay. So he's like saying, okay, get rid of all the posterior interferences. So anterior contact in centric relation can be verified. So he's like saying, if you get rid of all the posterior interferences and you have an anterior stop right there, that's what he wants to do. In my book, that anterior contact right there, if it's truly occurring at the same time as posterior, to me, that's anterior interference. Okay. Now, he's then saying, have the patient clench down or postural closure. And it is indeed true that some people will naturally slide forward, even if there is no inclination interference in the posterior. And he's saying that we need to allow that. Okay? And he's also saying on the right side, on the right page, 193, as the patient goes forward, you check the occlusal marking and you provide relief for that in the upper lingual contour. Whether it's upper lingual contour or lower incisal edge, doesn't really matter. Okay? Now, once you have that satisfied, if you go back to the centric position, you're going to end up having anterior slight open contact, just like the drawing says, 193. You know? Now he's gonna so what was the point of insisting on the very first picture on the upper left side that you want to have an holding stop in the front? So to me, this generation of people, just like our parents, they just keep saying the same thing over and over and over. They think like if you just keep saying the same thing over and over, it becomes truth. No, logically it does not make sense. And all of the rest of the chapter, they are trying to talk about things, but when you follow through all of them at the end, essentially, whether you want to call it long centric, whether you want to call it looseness of the condyle, whether you want to call it wide centric, or whether you want to call it just range of centric, whatever it is, that's what it boils down to once you satisfy all that. So at least the way from what I'm thinking, if you follow the logic, you come to the conclusion the centric relation is not a needle point. Doesn't really matter what you call it. You want to call it long centric, wide centric, range of centric, whatever it is. I don't care. At the end, centric is not a dot. Now, this makes a little bit of a, some people get confused when they're doing restorations. Okay. But what this really means is that you have to allow the occlusal context in the posterior to be free of lateral interference. That is the most key important thing. I think I mentioned to you early on in our meeting here, I told you that when I started, when I was in my residency, pros residency, and I didn't know what the hell I was talking about, obviously, but after my director gave us a 2-day lecture on occlusion, I had asked him, so if you were to summarize the whole thing, all the different things you talked about, what is the most important thing that I need to never forget? And then he said, never forget your mandible has the ability to move sideways. Because we all know it can move this way, but don't forget, it moves this way. And your restoration has to allow that. If you figure that out and you can do it at the chair side, then you'll be fine. But when you look at most of our patients, what do you see? You see lower buccal cusp. I'm talking about here. Lower buccal cusp coming out. Upper buccal cusp, they're just laying down like this. Okay. Front teeth, lower front teeth, upper front teeth, they're just laying down like this. Well, if my mandible wants to have some looseness, what gives? Well, those teeth. That's why they keep breaking. That's why their periods break down. Okay, at least a significant part of it. Okay. So, so at least, when I'm doing my restoration, I make sure that you have to sort of exercise your judgment call. What I mean by that is, let's say if I'm delivering number 8 crown, okay? If I can have it my way, veneer, crown, whatever, I make sure my teeth, my new tooth does not have traumatic occlusion in centric stop or in protrusive, excursive, whatever. If the rest of the dentition is tight, but the patient is not complaining, I let it be most of the times. And I don't see any major immediate breakdown. I am not going to go out of my way, at least not to make my number 8 touch the same way that the rest of them are touching. To me, the fact that most of the patients don't have good occlusion is the same thing as majority of Americans are obese. That does not make it healthy. That does not make it optimal. It may be normal. Normal is not optimal. Okay. So when I do my, implant restoration, when I do my composite, when I do my crowns, when I do my veneers, I make sure that mine is the last one to come in contact in that excursive movements and whatnot. Okay. Just remember that. Okay. Now, it is actually true now in a slightly different, I hope this doesn't confuse you, but let's say if I am doing number 8, and sometimes it looks like number 8 might be coming in contact, and I'm like, there really isn't a whole lot I can do to make it out of occlusion. Well, sometimes that that contact is coming from the fact that the patient has an occlusal interference in the posterior, and the jaw keeps shifting because of the interference. In that case, I may have to touch that interference. Okay, that's causing the mandibular movement, so that my restoration is going to be vulnerable. Okay, so just kind of keep that in mind. Okay. Okay. Let's go down on the left-hand column. 194, left-hand column, about halfway down. 1, 2, 3, 4, 5, 6 paragraph. In the absence of any centric relation interferences, it has been our experience that the difference between centric closure and light closure from rest rarely exceeds 0.5 millimeter. And I'm going to say, I don't have any problem with that. Okay. All right. Okay. Now, um, I'm just trying to, because I don't want to keep on reading these things that's kind of like I sort of disagree with many of them. Okay. All right. Um, let's just go to the part where he actually talks about 195. I think this is more clinically relevant. Providing long centric by equilibration. Okay. Now, let's, on the right-hand column, 195. Okay. Second paragraph, I'm going to start reading from there. There is no relationship between the length of a slide and the length of the long centric. The length of the slide is a result of interferences in the teeth. So he's talking about just overall, just occlusal equilibration. Okay. He's not talking about equilibrating from centric relation to long centric. So he's talking about there is interference. So we're not even a centric relation. Okay. The length of the needed long centric is dependent on the anatomy of the condyle disc relationship and varying patterns of muscle activity in different patients. Absolutely. They say almost everything exactly correct and then they deviate from that. Just drives me crazy. Okay. Many patients with long slides require no long centric when the interferences are eliminated. However, when the equilibrated mouth ends up with a longer long centric than the patient needs, it is not usually an indication for restoration of the entire occlusion. It will cause no discomfort or harm since the patient will use only as much of the long centric as it is needed. So there is an interesting statement there that I thought that I wanted to share with you on that. And to a certain extent, I sort of agree with that. He has a wrong reason for saying that, but I kind of agree with that statement. So let me read that again and see if you can catch it. However, when the equilibrated mouth ends up with a longer long centric than the patient needs, meaning in centric, if the front teeth don't touch and the overjet is more than you think the patient really needs, okay, that's what he's saying, it is not usually an indication for restoration. It is not an indication for you to go back and restore tight occlusion. Okay? It will cause no discomfort or harm since the patient will use only as much of the long centric as is needed. And you know what comes to my mind when I'm reading that? I go, what about all those people who tell me to give patient steep anterior guidance, canine guidance? See, those people, when you follow those people and you give them somebody very steep anterior guidance because you want them to become vertical openers, okay, and vertical chewers, okay, you're actually doing exactly opposite of this, what you're saying. What Dawson's saying is that if you give people more freedom than what he says you need, okay, meaning that you accidentally end up with more anterior overjet, he's saying, when everything else is being equal, he says, there is no need for correcting that. There is no discomfort or harm. Okay? It's a very short sentence there, but it is, to me, I was so glad to see that. Yes, Mari.
Isn't it the same as the some class 2 patients?
Yeah, exactly. Exactly. Okay? And this is exactly why I keep telling you When you give somebody a splint night guard, give them anterior freedom. Okay? Posterior stop, no anterior guidance. I tell my left, no anterior guidance. If it really makes you nervous, give them anterior contact after about 2-3 millimeter slide. Why? Because if there is no contact in the front, when everything else is equal, there is no pathology developing. But if the front is touching too much, then there will be pathology developing. Okay? So that's the key thing that we have to remember. Okay? So it's not just me who's saying that. Even Dawson, even, this is the frustrating thing about this book. And now I really hope that you can agree with me why I choose this book as the first book in studying occlusion. Not because this is such a perfect book, but because it's full of irony, in a nice way, full of dichotomy, full of different messages. It confuses the hell out of people. That's why when somebody, new person who is independent study learning, wants to learn about occlusion, and they go, Dawson is a good book. They go out and read, and they don't get any better. If anything, they usually walk away with the wrong message, because the message that you really need to get is so nuanced. It is so easy to remember. I need to have my front teeth contact. But when you actually get the juice out of his discussions, you realize, no, actually, what? You know what? No, I don't really want my front teeth contact. Okay. Now, the next sentence paragraph is interesting. In some patients, the interferences to centric relation are so severe that their eliminations require extensive flattening out of the occlusal areas between the convenience context and centric relations. Convenience context, okay. Although what he's primarily talking about posterior now, right? Although such gross contouring will not cause any actual discomfort, some patients may complain that the flat surfaces make it difficult to chew meat or other fibrous foods. They may relate the feeling to the feeling that their teeth are not sharp enough. It is sometimes necessary to restore cuspal anatomy to such occlusions to give patients efficiency along with the comfort that goes with a harmonious gnathic system, harmonious mascatory system. Now, I want to say this here. So, obviously it depends on what we mean by extensive flattening, okay? Do you remember what I always say? I say, we don't really want flat teeth, okay? Because flat to flat is inefficient chewing, absolutely. But your cusps do not have to be, like a tiger cusp, okay? So that's why I always say to you, when in doubt, take a look at, when in doubt, take a look at the lingualized occlusion concept. Okay. If one side is flat, the other side does not. We don't want that to be flat. Okay. If one side has a lot of cusps that's well developed, then you can have some flat, that your new crown that you're going to give them. What you don't want is your cusps to be locked in. Okay. Okay. Now going down 195, Second paragraph from the bottom on the right-hand column, he says, I should also point out that the orthodontic procedures should be considered as an alternative to equilibrium procedures that would occlusion procedures that it would mutilate the occlusion. Okay, fair enough. One thing I will say is that if somebody truly has malocclusion, it is rare, especially if they're done with growing, it is rare that you're going to have orthodontic treatment in itself provide stable occlusion in the long run. That you are going to need some occlusal equilibration at the end. And if people say, well, the old days, we didn't have to do occlusal equilibration. I go, yeah, but the old days, people didn't live that long. When somebody sends me picture of an Aboriginal person, people living, far away from civilizations, and they go, oh, they didn't, look at their teeth, da, da, da. I go, yeah, those people didn't live that long. We are actually doing what human body, what humans have not done going back, 1,000 years. They didn't live that long. It's rare. It's rarity, you know. So we want to try to optimize our things as much as we can. Okay. Okay. So now let's take a look here. Let's see. Reading of the marks, page 196. I think, to be honest with you, uh, um, those of you who have worked with me, you know that I don't bother checking using two different inks and things like color and things like that. Um, it's up to you. To me, probably the most important thing. Um, so take a look at the picture there. Um, page 19. I'm sorry, figure 19-3. Gentle tapping on the red marking ribbon shows interferences to postural closing. Yes, but it can also show you false marking depending on how deep the overbite is. So when the patients go tap, 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 to me, I actually don't like it. Now, figure 19-4, see, that's the thing that I just don't get it. That they're showing you the picture. So Dawson, or the operator, is having a bimanual holding of the mandible, trying to seat the patient into centric relation, and an assistant is holding the marking tape. I mean, can we make it more complicated, please? Right? No. You know what's actually more important than that? He talks about it. I was kind of going back and forth looking at it, but I couldn't really find the sentence where, oh yeah, here we go. On page 197, on the right-hand column, okay, that little book, the little box that he says, it is very important to check each tooth digitally for any jarring from the light rest closure. What does he mean by that? Remember I told you that when I'm checking the marking of the front teeth or even bicuspids, when I put my articulating film in, I hold, assuming they're class 1 and 2, I hold the front teeth from the facial aspect with my fingers so the teeth do not get pushed out when they are marking. If the teeth have fremitus, they're not going to mark. So to me, it's more important that I'm able to put my fingers on the facial aspect of the upper teeth as the patient's closing. I cannot do that if the patient's tap, 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 tap. So I'm not suggesting that when I push or at least I prevent the teeth from getting pushed out and then I have the patient just bite down or guide it in CR, and then have them go through excursive movements. It is, to me, important for me to be able to see the marking. Okay? So please remember that. You need to, in the upper incisors and the canines, you can hold the facial aspect of the tooth structure as the patient goes through excursive. And then if you feel the teeth moving, pushing out, and oftentimes if it's really obvious, I will actually have borrow patient's index finger. I'll have the patient place the tooth on the front aspect of their upper tooth, and then tell them to bite down, and then tell them to slide their jaw around. And then they're gonna notice, oh, my tooth is moving. Exactly, that's why it's getting loose. That's why it is loose. Now, some people might say, well, Dr. Lee, if aren't you pushing it in? Aren't you, the tooth wouldn't touch it if you didn't push it in. And I'm going to say, well, guess what? The tooth has that range of movement because of the fremitus or mobility. Maybe the tooth needs to get firmed up to here, but it was orthodontically moved out because of the bad occlusion. So if my lingually placing of the upper teeth causes the teeth to contact, I'm going to say most likely that is potentially a problem for the patient. So I'm going to go ahead and still push it in when they are moving, marking, and I'm going to go ahead and do the adjustments that's necessary. Now you have to gauge it against what's acceptable in terms of how much tooth structure is left. The aesthetics of it, sometimes it forces the front teeth to become too thin or too short, and you have to make sure that the patient understands what it is that you're trying to do. Okay? Okay. So, so, okay, let me see. So underneath that box there on the 197, he goes on to say that it is easy for mobile teeth to be moved rather than marked by ribbon. Checking each tooth for such movement while the patient taps is sometimes the only way such interferences are picked up. It is often necessary to hold mobile teeth in place with one finger while the patient taps in order to correctly mark them. If you can do that, fine, I don't care. The way I do it is just go into centric and then go into excursives, and that gives me the marking that I'm looking for. Okay. Next page. 198 on the left-hand column, second paragraph. When patients tell us that their teeth feel fine when they are lying down, but the teeth are in the way when they are sitting up, they are really giving us important information. They are telling us, in effect, that their centric relation is all right, but they need the freedom of a long centric. I'm going to say they're fine, but what they're really telling us is that they need a range of centric relation. They need the freedom throughout the range of the centric relation. So this is actually interesting. Page 198, again, on the left-hand column, the bottom paragraph. If restricting an occlusion only to centric relation is sometimes bad, restricting it only to an acquired habitual closure is worse. I absolutely agree. Because that habitual bite is what? It's CO, maximum unicuspation. And usually, not all the time, but most of the times, That is the jaw settling into a position despite having all the interferences. Well, but what I'm really happy to hear is that uh, he says that if you keep somebody only in the needle point centric relation, that it is sometimes bad for the patient. He at least acknowledges that in that sentence. Okay. So don't fall for people who are telling you steep anterior guidance, steep anterior guidance, because that's what they're advocating. On the right hand column on 198, the last paragraph. Because of the permissiveness of long centric, there are really no disadvantages to providing it. There are no disadvantages to providing wide centric or range of centric relation. Since we are talking about a freedom of rarely more than 0.5 millimeters, if you're class 1, 5 millimeter from centric stop, needle point stop to end, 5.5 forward, 0.5 to the right, 0.5 to the left, okay? Absolutely no problem. I am willing to make peace with that for most people. Okay? It says it does not create any problem for restoring the posterior occlusion form with good morphology. If the patient has it, does not need it, he or she does not have to use it. That's right. So, so these are the things that most people don't remember when they read this book on their own. Okay. But remember, you want to call it long centric, wide centric, range of centric relation, whatever it is you want to call it. Make sure you provide enough of a freedom where there is no interference, where there is no fremitus, okay? And that the front teeth are hopefully not in occlusal trauma. Okay. So if I come to this point of page 200, plane of occlusion, you know, and then Dawson gets into the old habit. I'm going to read page 199, the box, the cover page for chapter 20. He says, principle, the plane of occlusion is acceptable if it permits the anterior guidance to do its job without interference. Plane of occlusion has nothing to do with anterior guidance. What's that got to do with anterior guidance? He keeps going back. He keeps going back. I hope none of you will say that same thing about me when I have a bad habit of reverting back to, these old guys, they just can't change. No. Okay. All right. All right. No. Okay. So when you look at the picture, in a curve of speed, okay, it's interesting, honestly. Okay. So curve of speed, curve of Wilson. To me, curve of speed does not really include the incisors. Curve of speed is really bicuspid to the molars. Okay, canine to the molars. Okay. And curve of speed is related to the root orientation of those teeth. Same thing with curve of Wilson. Okay. As I said, when they show me these front teeth, okay, that are taller than the posterior teeth, what they are doing is they're making an observation of majority of Americans and saying, ah, most people have that, that's normal. So they must be optimal. No, it's not. Just remember that. It's not. Okay. By the time when you are setting up your patient's teeth, whether it's denture or whatever, okay, by the time you satisfy minimal anterior contact, okay, and that is free from excursive movements and not heavy contact and phonetic clearance and neutral zone and all that, you come to realize you don't want overbite of more than 1 millimeter at most, and or even like 0.5 millimeter probably. If you think about it, remember I said earlier, almost everybody as you get older becomes class 3 edge to edge. So assuming that is the case, if somebody has a 2 millimeter overbite and they becoming more and more class 3 edge to edge-ish, what's going to happen? The front teeth are going to at some point gonna have traumatic context. Either they're going to break away and wear away, or they're going to have flaring of the teeth, periodontal problems, which you see a lot with our patients. But instead, let's just say, ideally, we set them up with 0.5 millimeter overbite. And obviously the picture is much more complicated, but let's say when the patient's jaw goes forward with 0.5 millimeter overbite, what happens? They barely touch in the front. If the patient becomes class 3-ish and edge to edge, at most it just requires a little bit of occlusal equilibration so that they don't bang too much. They remain healthy. As you get older, as you become class 3-ish, that normal, so-called normal overbite becomes your enemy because you just can't do enough grinding to provide relief for those patients. Okay, so in an ideal world, okay, what you want is to make sure that the lower front teeth do not create too much overbite, even if they're not touching. Okay, to me, I think that's going to make a big difference in the longevity of your cases. You know, it's kind of interesting. He's showing you these articulator tools that are primarily based on old uh, um, um, sphere, monsoon sphere. I'm trying to figure out if he actually talks about that specific word. Uh, Let me just try to, if one of you knows what I'm talking about. So it's starting page 201. He's showing you that articulator with um, with a flag. He's using the word here, procedure, using a simplified occlusal plane analyzer. Simplified occlusal plane analyzer, SOPA. Okay. And when you go to the point here, and then he gives you this little metal rod, okay? You make it contact your lower front teeth, and then assuming that that was a Facebook used articulator, it has that curvature that goes to that little line drawing on that flag on that articulator. And then when you go to the page 202, there's a little X up there, okay? And then they want to draw a sphere from that going through the condyle going through the occlusal plane, and they're saying that should be ideally your occlusal plane. Again, average value. Okay? To me, this goes back to a guy named Monsoon. Okay? He was a dentist, believe it or not, before 1900s. I want to say he's a French guy. I forget. And there is a concept called monsoon sphere in dentistry. And he basically says something to the effect that when he observed so many people's occlusion, uh, uh, um, skull samples, you know, the things like that, he came to the conclusion that that little X mark there, it resides somewhere at the base of the skull. And from there, our curve of Spee, curve of Wilson should follow that sphere. It's no different than there is a aesthetic dentist standing in front of a room, hundreds of thousands of dentists, and saying that all of our patients number 6, 7, 8, 9, 10, 11 proportion should follow the Greek proportion. Yeah, you know, I mean, I have to admit, Greek proportion is beautiful. But there are a lot of people's mouth where that proportion teeth will not look good. Everybody has to be custom made, you know? Same thing with dentistry. I'm not going to say that these, I think I do say in some of my occlusion lectures, I say, and it's not because I'm racially biased, but give these people a lot of credit. This early fathers in dentistry, at least dentistry. I don't know about other disciplines, but in dentistry, then in modern dentistry, no doubt about it, it has been led by, Caucasian males in 18th century, 19th century, and 20th century, and 21st century even. Okay? And they tend to look at the world through their view, history, politics, and science. Okay? There is no need for us to take away their credit. They've contributed tremendously. We just need to recognize their limitation. It's kind of like when we grow up, we finally realize our mommy and daddy are not so perfect after all, that they are just another human being. You know, our forefathers in science, in dentistry, they didn't mean anything bad, but they just try to understand the universe the best way they know how, given their background. Okay. So, and the reason why I'm mentioning all that is because you look at this, and so now they're going to be doing that analysis, and they draw the line into the lower caste, you see, because that's where they need to be restored to. And then they're going to just arbitrarily, guesstimate that in the, with the putty. That's what the pictures in 203 looks like. And they're just going to chop down the teeth. You know, I'm like, what's up with that? That's like, I think I mentioned to you guys, it's like, okay, I'm only 5'6". They're going to say you're deformed. We need to make you taller. They're going to go to Mari and they're going to say, you're too tall. We're going to chop it down. You know, I mean, well, how ridiculous is that? Right? But if you look at our history, that's what they exactly try to do in Western culture. Well, in any culture, to be honest. Whoever the rulers are, they get to decide how they want everybody to look. Okay? So So, but in dentistry, that's what they try to practice in dentistry as well. That's why I don't want to dwell too much on these aspects of this book, the technique aspect, because a lot of it is just truly, just really closed-minded technique in a bygone era. Okay. Now, what is important here is actually there are some other parts that are very useful in this chapter. So let's take a look at this. Starting with page 204. To me, as a clinician, now is the more interesting, the thing that's going to become much more useful for your daily practice is coming, right? You know, so take a look at this. So it's interesting here. They say the principle. Let's just go down to Curve Wilson. Okay, Curve Wilson. Okay. Okay. So he says, let's just read that part a little bit. So it sets the tone. The first paragraph in that section. The curve of Wilson is the mediolateral curve that contacts the buccal and lingual cusp tips on each side of the arch. It results from inward inclination of the lower posterior teeth, making the lingual cusps lower than the buccal cusps on the mandibular arch. The buccal cusps are higher than the lingual cusps on the maxillary arch because of the outward inclination of the upper posterior teeth. They're supposed to be, not all the time though. There are two reasons for this inclination of posterior teeth. One has to do with resistance to loading, yes, and the second has to do with the mascatory function. Okay. If the buccolingual inclination of the posterior teeth is analyzed in relation to the dominant direction of the muscle force against them, it will be apparent that the axial alignment of all posterior teeth is nearly parallel with the strong inward pull of the internal pterygoid muscle. Well, I don't know if that's really what I would have mentioned first. Figure 20-7, internal pterygoid or medial pterygoid. Okay. To me, I mean, that's important. No doubt about it. But there is something that's even more important than that in terms of chewing force, the vector force. Which one is that? That's the masseter muscle. Masseter muscle. Masseter muscle is far more capable than medial pterygoid. It puts a lot more force. Now, here is an interesting concept I want you to think about that sometimes I think. When people become clinchers or they just like to eat a lot of hard food, they kind of go hand in hand. Many times those patients and clinchers, they create very broad mandible. They become very boxy, square. And in our culture, we say it's okay for men to have that, but not for women, for example. Man, that's kind of stupid. But here's the thing, and we are told that's because the masseter muscle and the buccinator muscles become way too toned out because of all the exercise they've had. But there's one more thing that I think that also plays a factor, and that is take a look at the mandible in picture figure 20-7 and then 20-12. Take a look at the mandible. So if you are, and take a look at that, and then now take a look at me. Our mandible is not straight up and down in the posterior segment. Our mandible is tilted a little bit like this, right? And that's one of the reasons why there is curve of Wilson. Okay, curve of Wilson, because as the teeth come up like this, buccal lingual come up like this, buccals become taller than the lingual. If I'm going to now concentrate on my left side. If my masseter muscle is on the outside of the mandible, there is internal pterygoid or medial pterygoid in the middle part, mid part. and they are putting a lot of hard food chewing, clenching, okay? Masseter is going to put more force, okay? What's going to happen if you do that for 20, 30 years, my mandible will start to be bending because the bone is a living tissue. They start doing this. This is why a lot of people's second molar region, the teeth are literally tilted 45 degrees. Okay? Obviously, I want to minimize that tilting as much as possible for my patients because that becomes sort of like, if it doesn't happen within a few weeks or a few months, obviously, but it does happen in the long run. And we have to recognize that mandible is a flexible bone. So that being said, these are the reasons why I cannot engage in these conversations with my patients. But this is why I tell my patients, don't eat hard food too much. Okay? Because remember what we said earlier, everything we do with our body creates some sort of or elicits some sort of adaptive response. It's never neutral. What we do is either beneficial for our patients, our body's health in the long run, or potentially harmful. You know, every day what we eat matters for our overall health, not just my cardiovascular and liver and kidney function. It matters for my teeth, my jaw. It's unfortunate that we do not get educated about these things. Okay. Okay. From dental school. That's why there's so many unknowns that we are just not aware of when we are dealing with patients. You know. So it's important that we recognize all these complex interactions among different parts and how they will have long-term consequences. So let me tell you another clinical situation that I can share with you. So this one is you're gonna cringe a little bit. Well, not too bad. So my sister, my older sister, she had bad orthodont when she was younger. So her teeth became mobile, loose, they're compromised. She has an anterior open bite. You know, anyway, to make the long story short, she had a dentist who splinted the upper front teeth, and they've been stable for quite some time. At least two centrals. I don't think the laterals were just a central. Anyway, about 30 years ago, a little less than 30 years ago, I gave her my hard acrylic splint night guard because she had TMJ symptoms and things like that. And I equilibrated occlusion so that she's stabilized. She's been wearing the same night guard all these years. Okay. They didn't wear down too much. You know, I would see her once in a while. She lives in Texas, comes in. You know, she used to live in California. That's why I took care of her back then. Anyway, so she's been stable like that for 30 some years. Okay, upper anterior is open bite. Okay, and then she calls me up recently and says, Tom, I think you need to make me a new night guard. So I go, why is that? She goes, I think my teeth are moving. I go, why is that? She's older than me, okay? And she goes, yeah, you know, lately I wear my night guard and there is a tooth in the front that hurts a little bit, and it doesn't seem like it fits right. So I go, really? And then I said, you're not eating any hard food? No, no, not really. So not since you told me. I go, okay. I said, and then my sister has a son who is a dentist. My nephew is a dentist. So I go, So I said, have you had your son work on you recently in anything? There's a little pause, and she goes, yeah. As a matter of fact, that bonding to connect my teeth, they were getting little loose. So he went ahead and fixed it. So I go, I'm sure he checked the bite at least. And I know it was the anterior open bite. But yeah. That part is fine. I go, yeah, but he did not make adjustment to your night guard, did he? My sister pauses, goes, no. And you've been wearing the same night guard that was fitted to your previous splinting composite. And when he now fixed it, the shape will not be the same. So every night you're wearing the night guard thinking it's protecting you, it's actually been hurting your front teeth. And it's not necessarily the spot that's holding up, because the thing is going to rock. So if it's holding up here, but it rocks, and now this part is the one that's applying more force, this is the one that could be hurting. And she goes, I think you're right. Now, my sister and my brother-in-law, they used to work at NASA. Okay, they're retired now. They used to be part of the space shuttle team. And I remember them telling me one time they were teaching some other country how to make rockets. And 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 they would copy the rocket cone, the portion that pushes the aerodynamics of the rockets. And I remember them telling me one time, they said, yeah, they would copy the shape of the cone and this and that, but it would still fail. And I go, why is that? And they go, that's because they didn't understand the metallurgy. So the metal that they use for their rockets, it was inferior metal. They didn't know how to make that. So as it goes into the supersonic, it gets too hot and the shape starts to get melted. On Earth, you'll never be able to visualize it. And by the time they retrieve it, the whole thing went through so much, re-entry into the Earth atmosphere and burnt up and all that. They couldn't figure it out on their own. And they all thought that it was just only in the shape. But then when we consulted with them, we found out, no, it was because they used the wrong metal. It changed the shape. And I said, remember that story you told me? He goes, yeah. I go, just like that, between you and your son, you guys didn't think about how the interaction is between how he made the little bonding change and how that's going to interact with the night guard. So they go, oh, okay. So, and then they were going to go visit him because he lives in a different state. Yeah, have him take a look at that and see. He knows, he had visited me actually. So he knows how to check the internal intaglio of the night guard to check it using the PVS and give the relief. He needs to do that. I was okay, I'll do that. Well then, but guess what? So that was a conversation we had like 2 weeks ago. And I guess my sister was minimizing the discomfort she was having. So since then, they actually went to a dentist in their hometown before they went to see the son. And my sister calls me up and says, Tom, I have a problem. I go, what's that? According to my dentist here in Dallas, The son lives in North Carolina. In Dallas here, I have a 10 millimeter probing. And I go, oh shit. 10 millimeter probing. And I took a look at the probing, distal lingual on number 10. You go like, yeah, I can put the picture together here. Somebody who had compromised alveolar bone ridge because of bad orthodontics. Teeth were barely kept in place for long term. And now the night guard that was helping you keep things became the villain because it was pushing out. Okay. Now, this time around, I couldn't verbalize the fact this is all from that bonding. You know, just like my own tooth, other than fillings and crowns, the fact that I am missing number 31 is because of my friend who perforated when he was doing root canal. And he claimed that the the amalgam filling that he had to replace was already pathologically involving pulp. Funny, I didn't really have any sensation before, no pain. So what I'm trying to say is this: a lot of times, and I'm not claiming I'm perfect, you know, there are situations where I have to go back and redo some things and so forth. But a lot of times, our well-intended work from the dentist creates the unintended consequence. Because it is not an easy picture. It's a complicated total picture, right? So, so don't feel bad. Nobody expects us to be perfect. Certainly not God. God does not expect the dentist to be perfect. Okay. So, so the what's really important for here, to be honest, and the reason why I'm saying this, as we're about to get into the more juicy part of the clinical dentistry, is that we accept the fact that we're not gonna be perfect, yet how do we then make it so that it's less likely to cause problem? Is in our ability, everything that we do our best to be thorough. So if there arguably, let's say if there are 10 factors we have to check, if we do a good job with 8 or 9 of them, when we miss a 1 or 2, most likely it's going to be okay. But if we become sloppy or we're always in a hurry, so out of 10, we only check 5. Then that's when it becomes a problem. You know, it's like long time ago, because I'm ethnic Korean, so I watched some things that happened back in Korea with a little bit more interest. I believe it was believe it was right after I finished my prosthodontic training that an accident had happened. I'm gonna get back to that. Mylene, yes.
You were mentioning about how the masseter was kind of contributing to the angulation of the mandible. Is that
Uh-huh.
correct?
Yes.
Okay. And I was just curious about it because and then on the picture 2013, it has that picture of the condyle
Uh-huh.
and the pterygoid there. So, but it brought to my attention, like, are all the muscles of mastication motor neurons? Are they involuntary? I mean, I just can't believe, like, how does one side, if it feels like a a bolus of like a small particle. I mean, I'm not thinking like, okay, so my right medial pterygoid needs to contract. I mean, how does it, is there a portion of the muscular innervation that's like involuntary? I just don't see how they can all coordinate together.
Well,
From a voluntary, like if I'm
yeah, yeah,
working
yeah, yeah,
out and
yeah,
I'm
yeah.
contracting my muscle.
Well, I mean, I think that's a good question. I think I'm gonna say not all of them are voluntary. For example, the mid fibers or mid lobe of the lateral pterygoid. Do you remember where that is attached to? That is attached to the disc. That's not voluntary. That is just doing its best to stabilize the disc position. But the superior and the inferior lobe of the lateral pterygoid is involved in us moving the jaw forward and back. When I go my jaw forward and back, the 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 the, the, the different bellies of the lateral pterygoids contract differently to hold on to the different parts of the condyle and the disc. Okay, so I'm sure some of them are involuntary as a reaction to what the voluntary muscles are doing. Okay, it's
Because
kind of
the
yes,
the question is like, because I'm not thinking, okay, close, close, close.
no,
Like
of course not.
the
Oh, that's how our rest
the
of our body works.
I'm just thinking like, okay, I need to eat now, and then
Right.
so it just takes off. So
But
I don't
like
know.
if you look at some of the I'm gonna say documentary because I'm not gonna say I'm researching it, but if you look at some of these documentaries, they talk about how our body's cognitive function works. Most of the times, like for example, I thought about raising my hand and using my hand as a gesture to emphasize what I'm doing. Most of the times, the neurologists, when they do the brain function studies, what they say is that our body starts to either our body is so fast or we have a duality to our consciousness that before we start doing certain things consciously, our body is already doing it unconsciously. Our unconscious self is milliseconds ahead of our thinking. At least that's many times I have seen these neuroscience, science uh, uh, documentaries that they talk about human functions. That's what they talk about. Like, oftentimes, and like, for example, when we are driving, when you learn voluntary movements, you have to think through everything. But once you get to be a certain point, right, you are doing things not only without thinking, but even if you're thinking about it, you realize you're already doing it split second before you're thinking about it. So, the neuroscientists were postulating, okay, is it that our ability to overtly think through goes through multiple layers of thinking, therefore it's a little slow? Or is there a subconscious level of our control, body control, that our cognitive function actually just follows that? So it's our subconscious, involuntary, that's already sending signal to our muscles, do this, start doing this, as our conscious level, voluntary movements are just getting caught up. I don't know the answer to that. What I do know is that there is constant balancing act of different muscles in our body. It's too bad that our author has decided to show us only medial pterygoid on page 206, because if they're going to use that picture as an evidence of seeding of the condyles into the into the medial pole of the condyle. Okay, I'm gonna say masseters have the similar direct vector force functionality to that. Yes, Mylene.
So I was thinking like maybe the masseter is like heavier too because it's got to
Yeah,
balance out like the pressure of the tongue and all of
absolutely.
the forces pushing out.
Right, right. Exactly. To
I was going to make
me,
a comment too, real quick, about
yeah,
that.
please.
Sorry, about the picture in 22. So speaking of the,
20
um,
dash 2,
yeah,
20
now that you
dash.
mention it,
Uh-huh.
um, with respect, now that it's mentioned, I think that picture, it's like it was true in that era because the patients that were coming in were really heavy, hard diets in the back posterior, like really hard foods a lot, grinding a lot, mismanaged occlusion, loss of VDO, and super eruption of the anterior teeth. That was your typical presentation of most people, I
Mm-hmm.
bet, because back in the day, that's what they were doing. And it
Yeah.
was mismanaged occlusion. But nowadays, I bet if you were to take a little bit closer look at how people were doing, I think that architecture might be different.
No, I agree with that. I agree with that. And I don't think it's a an accident that if you look at the two pictures that he's showing us on chapter 21, the very first page of chapter 21, posterior occlusion, he's got two different mouths there, right? And if you look at it, in both instances, the anterior teeth are higher level in occlusal plane than the posterior teeth. Okay, and the one that's more visible after the crown's placed and all that in the bottom picture, you look at it, it is not a coincidence that there is significant abfraction lesion there, which is an indication that the front teeth are banging too hard. Okay, so so I think it's really important that we understand this from a multifactorial perspective. Okay, but there are a couple of things that before we move on, the plane of occlusion concept that I wanted to share with you. Ooh, it's 12 o'clock. The game's coming up. So so
Yes,
before
Dr. Lee. Sorry,
what?
but can I leave the meeting?
Yeah.
Because um
Okay. Okay. Yeah. I know. People want to watch the game. Same here. Okay. So it's 12:05. Okay, we're gonna stop here because
uh,
so we won't see another World Cup game for 4 years. So we will pick up at Curve of Wilson next time when we're meeting. Okay?
I'm
Sounds
sorry.
good. No. I didn't realize the time just flew by. Today's good. Okay? Let's go enjoy the game. Thank you.
Dr. Lee, I was going to ask you a couple questions just
Yeah,
before
you
you
can
go,
stay
though.
on. You can stay on with me.
Nice to see
Okay,
everyone.
everybody. Have a good day.
Okay.
Bye.
Thank you, Dr. Lee. Have a good
Of
day.
course.
Thank you, Dr. Lee.